Okay, so this is Farm 2. Farm 1 is over. You guys all completed that. Congratulations. This one is like double the material of Farm 1, so sorry about that. But it's going to be great. It's going to be good. Just an overview of the class. We have syllabus should be up there, so you can see that. There are going to be, I should have uploaded a schedule. If not, I will do that. You'll see the lecture topics and kind of how those break down. I apologize for my absence and not having stuff like, your behavioral meds before, you had your test on that in CMS. But it's the nature of the game, unfortunately. At least this time we didn't have like 3 people on maternity leave like it was a few years ago. So you only had 1 person. The assignment, there's going to be 4 assignments that will go with the test. They're going to be prescription writing assignments, similar to what we did last semester. If you look, those will be in total worth 20% of your grade, so 5% each. Should be pretty straightforward, and those will be due the day of the test. So I'll make those and have those posted here pretty shortly. And they'll go over stuff we've talked about during that section. So like today, we'll talk about like seizure drugs. We'll probably have one that's based on a seizure med, so that we get some experience writing prescriptions for those. And then 4 tests for this one. Any questions about that? Pretty straightforward. I think that's it as far as. Otherwise, it's just more farm, You guys are already used to that. So where have I been? Took a month off, and now I have another little bundle of joy in my life, little Phoebe Wood. That was like not even 24 hours old, I don't think. They do these nice like little bougie photo shoots for the babies. Notice how they always have stuff on their head because their heads are horribly misshapen when they just come out. That's just how it is. At least for normal vaginal deliveries. But anyway, this one we had to use the sucker to get out, which was kind of interesting. Here's a good story. Bedside manner is good to have when you are, it's good for your provider to have when you're a patient. So we were getting ready to have my daughter, and everyone's getting set up, and unfortunately there's a lot of people giving birth that day. And so we were stuck in the triage room. We didn't even leave the triage room to go to like normal delivery suite. So it was a little cramped, and lots of nurses and the doctors there. And so the doctor was like, "Okay, Dad, you're gonna stand on this side, and are you gonna be cutting the cord?" And I said, "Yeah, of course I'll cut the cord." That was fun the first time. They said I couldn't use my teeth anymore, so I had to use the scissors. So anyway, so we were going along, and so we were, had the monitor on the baby and everything, and so. Also, the baby starts desatting a little bit. So, my wife is, pharmacist, so she was looking at that. She was a little concerned. I was getting a little concerned. The doctor was like, "Everything's good. Hey, Dad, just just in case the cord is wrapped around the neck, maybe, I don't know. I'll go ahead and take care of the cord." I'm just like, whoa, where is this coming from? Being very chipper about the whole thing. So fortunately, she came out, no cord around the neck, and I was able to cut it. I got a little blood spurt everywhere, but that's okay. So anyway, so she's very healthy and happy, which is good. Now she has a little baby sister. So on the left, you can tell how similar they look. On the left was my baby Lily, and then on the right is Phoebe. And then you ask, where are they at now? Here's Lily. She's about 1.5 years. She'll be 2 in May. And then here is Phoebe. So she's about a month old. Very cute. I think she's adorable. Together, I have a little video. I hope this plays. I said, no, stop. I said, be gentle. Please be gentle with her. Say, no, don't do some more. So since then, she's been a lot better with her and chilled out a little bit. So she comes up and she'll tap her on the head and say, baby, and that's good. So anywho, I also got to watch all of the Harry Potter movies again, and the extended edition of Lord of the Rings. So if you want to test my knowledge, go ahead. That'll be fun. Anyway, so any questions before we get started on the neuro stuff? Okay, you've already covered neuro, correct? So you already know epilepsy backwards and forwards? No, you didn't cover epilepsy? When did you cover that? You just did. This seems like there's some conflicting reports.
lecture says altered levels of consciousness.
Okay, this would count as an altered level of consciousness. Okay, great. So we're going to talk about. I haven't been testing it. That's perfect because we're going to go over the meds that you use to treat epilepsy today. Fantastic. If you guys want to turn off the light, you can feel free to reach over there. It's up to you. Anywho, so what is a seizure? Anyone know? Don't all have one. Yeah, it's kind of like the arrhythmia of the brain, I would say. You know, so we're having this kind of altered, abnormal firing. This discharges these action potentials of the neurons, and a very kind of they talk about hypersynchronicity and hyperexcitability of the neurons there. So we're firing too much too often. We want to prevent that, right? Epilepsy itself is just going to be kind of these collection of signs and symptoms. There are different types of epilepsies. I'm not going to get super granular in the different types of seizures. Where it becomes important, I'll talk about those as they come up in regards to the medications. But that's kind of the more kind of broad definition there. And then, so what status epileptic is? Anyone know? Yeah, there's kind of these like multiple seizures that occur. And so what do you call it, like when someone when they have a seizure and they come back out of it, the seizure breaks, and they're not really like at their normal mental status level yet, but they're just kind of still out of it. Post-ictal, right? So if you have someone who has multiple seizures and they never leave that post-ictal period, they never achieve that kind of baseline mental status, that's considered status epilepticus. So we see that most often in the emergency department where they come in, report a seizure, you know, and we'll talk about how to manage that and how it's a little bit different than a typical just kind of run-of-the-mill kind of seizure disorder. So anyway, lots of different reasons why you could have disruption of kind of normal neuronal stability, and we'll talk about resting membrane potentials and the action potentials again. And again, electrolytes are going to be super important for this, as we'll see, as we covered, you know, ad nauseum in previous classes. But things like head trauma, sleep deprivation. So if I have a seizure all of a sudden, that's most likely what it is. You know, CNS infections are a big one. It's one of the big things you have to rule out when someone comes in, kind of a you know, a first-time seizure that your patient has no history of that. That's one of the things you want to watch out for, is make sure they don't have any kind of CNS infection. For my purposes, in the toxicology world, we see a lot of drug use associated with seizures. So things like Theophyline. You guys remember where we use Theophyline? Was with asthma and COPD. So Theophyline used to be a more of a problematic drug until we stopped using it quite so much. Alcohol itself does not actually cause seizures, but you can have alcohol withdrawal that can actually cause seizures, right? And so we'll see that there's, you know, with a lot of like CNS depressants, there's a degree of adaptation that occurs where if you remove a CNS depressant very quickly from the system, you can have withdrawal seizures. And we'll talk about what that mechanism a little bit later on. Antipsychotics, which we'll talk about later on in this section when we get to behavioral med. Antidepressants can do this as well. And then toxic levels of anti-epileptic drugs. So when I say AEDs, that's what I'm referring to. And so just like normal antiarrhythmics can cause arrhythmias in the heart, too high levels of these anti-epileptic drugs can actually cause seizures for these patients. So it's one of those kind of fine lines you're walking on, where a lot of these drugs do have a narrow therapeutic index. And so we'll talk about meds that we'll do therapeutic drug monitoring on to make sure the levels stay right in the range. Because the problem is, if they get too low of a level, what could they have? You have a breakthrough seizure, right? And then if they get too high of a level, they could also have a seizure. So your job as a clinician is to try to figure out, like, well, what was the problem, right? Were the levels too low, or too high? And we'll talk about that. And then obviously non-compliance, as we just mentioned. If they're not taking the medication, then you can see some issues with that, which can be important, you know, considering how some of these meds can be very expensive, especially some of the newer ones that are coming out. They're still brand only. Insurance coverage can be a problem. You know, even like we see this a lot of issues with kids who have seizure disorders, like the parents don't really have their household in order and they don't have their meds being taken appropriately. That can lead to kind of breakthrough seizures. So lots of reason for this to occur. Now, normally what we're going to see is that you'll have this kind of abnormal repeated firing of the neurons that leads to this kind of sustained seizure for a period of time. I mentioned that hyperexcitability, and so we'll talk about resting membrane potentials and how we can alter that in order to help prevent seizures from occurring with certain medications. And so again, you know what normally keeps that resting membrane potential in check? Yeah, sodium potassium ATPase pump. So we're going to go back and look at that chart again of action potentials. But that's really important to make sure that's maintaining a normal stability. But we're going to find that lots of different receptors can affect that. So we'll talk about different neurotransmitters that can make that more hyperexcitable, more difficult to discharge. So we'll look at some differences there. The main things to note, though, are you're going to find that GABA is going to be our primary inhibitory neurotransmitter, right? So this is the brakes on the system. This is primarily how drugs like your benzodiazepines like Xanax work, by making GABA work better. Alcohol alcohol does this. When we talk about our barbiturates, they all are making GABA work better, and this is going to be the main thing that inhibits the system. Anyone know what GABA channels, when they open up, what they allow to flow into the neuron? Not potassium. Chloride, actually, right? So again, if you think about those resting membrane potentials, if I allow more negative ions to flow into that neuron, what happens to the resting membrane potential? Becomes more negative, right? And so as it becomes more negative, it's harder to discharge. It's harder to get to that set point where you would have those normal sodium channels open up and allow the action potential to occur. So we'll look at graphs in a second, but just keep that in mind. GABA allows chloride to flow in. That makes the cell more negative, and that makes it more difficult for it to discharge and have an action potential. On the flip side of that, you can see that glutamate is going to be our primary excitatory neurotransmitter. So glutamate has several different types of receptors that it'll hit on, as we'll see, but this is going to be primarily excitatory. So you can see a lot of damage that occurs if you have too much glutamate activity. This is what leads to a lot of arousal in the system is due to glutamate activity. And so you can find that there's kind of a balance between these two, where if you have too much GABA, the system will be kind of too hyperpolarized, and you're going to find that it's going to be very difficult for the person to have a good normal mental status. Versus too much glutamate, you're going to have too much activity, you're going to have too much excitability of those neurons, and that's where you can see seizures that occur, right? So, and again, looking at that resting membrane potential, sodium potassium pump is super important for here, for this to work, because again, they're going to be pumping sodium outside of the cell against the concentration gradient, pumping potassium into the cell, and that maintains that normal resting membrane potential, as we've talked about. And you'll find that in some patients, it will have kind of these predilections towards having an altered resting membrane potential level, and so that can be due to changes in the pump. It can be due to lots of different things: drug exposure, structural damage to the brain, different things like that can all affect that resting membrane potential. But the other thing, if you remember going back to our arrhythmia lectures, is that when you have an action potential, say like in the myocyte, what prevents that myocyte from having another contraction immediately? Yeah, so there's like an absolute and a relative refractory period. So there's a period of time after which you should not be able to discharge or have another action potential. Same thing goes here for the neurons, where if you alter that refractory period, if you make it so that another signal can come along and discharge that neuron, that's where you can see these epilepsies form, right? And so sometimes you can have, kind of localized seizures that will spread, and some of that has to do with these resting membrane potentials and also these refractory periods being altered, right? So when you are diagnosing a patient, I'm not going to get super deep into this, but medical history is super important, especially if they've had any history of seizures. If it's a first time ever happening, that should, especially depending on the age of the patient, it could just be that, okay, this is the first presentation of a normal seizure disorder, or it could be signs of something else that's kind of, could be potentially more, more deleterious to the patient. So, but always get a good medication list. This is going to be really important. One of the other things you always have to consider for a patient who has a seizure is that what does your brain run on for energy? Glucose. So if I run out of glucose, what could happen? You can have a seizure. So that's one of the other things to look at. So you might think of a diabetic patient, even though they're coming in, they're having a seizure. You gotta think, well, why would a diabetic patient have a seizure? It could be maybe they have, they had too much insulin on board. They forgot to eat or something, and their glucose is now down to 30, and they had a seizure, right? So you have to go through a pretty wide differential when you're trying to work up these patients. But again, good history, good medication list is always going to be able to help you with this one. And again, because normally for a lot of these patients, you're not going to have really any big physical exam findings between seizures. They could be relatively normal otherwise. Labs are going to be very useful for this, especially electrolytes. So one of the big ones you want to look at is going to be sodium. Typically, hyponatremia can be a big cause for seizures as well. We see this a lot, especially during the summertime when you have these like boot camps and you have patients who are not super physically fit, and they go out there and say, I'm going to go out in the 100-degree weather, I'm going to get super buff and toned, and then they don't drink enough water with electrolytes in it, and then all of a sudden their sodium comes back, in the 1-teens, and they have a seizure. That's another not uncommon presentation you'll see in ER, especially here in Florida. And the other things that can be useful, toxicology screen occasionally can be useful and give you an idea if maybe there's something on board, especially a lot of stimulant medications. If you think about things like amphetamines, cocaine, all of those can potentially lead to seizures occurring there. And I'll show you a mnemonic that we use in the tox world to help us with that differential. And then MRIs and EEGs can also be very useful for helping your diagnosis. So I'm not going to have you memorize this, but just to give you an idea of just how wide of a differential you can see with toxin-induced seizures, we use we love mnemonics and tox. We use this one called Otis Campbell, which is super long, just to give you an idea of just how wide this differential is. So things like oral hypoglycemics, right? So that would be all out of your diabetic medications that can drop your blood sugars. Organophosphates. Anyone know what those are? Those are insecticides, older drugs that we don't, older substances we don't use as much nowadays, but those are definitely on the differential. Things like Theophyline we mentioned, Tricyclic Antidepressants, which we'll talk about in a couple of lectures. Isoniazid, which anyone know where we use that? TB, yep, perfect. This is actually interesting because isoniazid itself actually will deplete the body of GABA. So it actually helps to prevent your body from making new GABA. So if I run out of GABA, guess what's going to be more active? Glutamate, absolutely. And actually, when you look at the biochemical production of GABA, glutamate is actually a precursor of that. So if I block GABA production, you're going to have way too much glutamate. So that's one thing to always consider. Salicylates like aspirin can do this. Anyone ever find camphor? Yeah, so it's kind of has a kind of like I guess it's kind of more like a menthol kind of smell. We don't see a lot of camphorated products much anymore because of problems like kids getting into camphor, eating it, and they would have really bad seizures. The cocaine, carbon monoxide. Again, if your brain is hypoxic, if you don't have enough oxygen there, that can also lead to seizures. So that's one other thing to consider. Anyone ever heard of the coma cocktail? I don't know what that is. So it used to be something that it was done more widely back in the days when you'd have a patient comes in with a depressed level of depressed mental status, and you would try to give them several things to try to wake them back up, essentially, right? And so sometimes these patients would be happening after a seizure, or would have depressed mental status after a seizure. And so some of the things you would give them include dextrose, right? So if they're hypoglycemic, you give them oxygen, you would give them Narcan or naloxone. Anyone know what you use that for?
To wake them back up. Drug overdose?
Yeah, so opioid overdose specifically, right? So if they overdose on their hydrocodone or something, you can give that to them. Because again, if you're not sure why they're mentally depressed, you can give them Narcan. If they wake up, then that's your answer, right? So those are three of the big ones. They also used to use thiamine and probably blanking on another one. They used to use physostigmine, which I'm not going to get into in these lectures, but they used to kind of, if you didn't know what was going on with the patient, you just kind of gave them this whole list of stuff, and if one of them worked, then that was your answer, right? So if you ever hear coma cocktail, that's what we're kind of referring to. Anyway, amphetamines, methylxanthines, which you mentioned, theophylline can be a methylxanthine. You know another methylxanthine? It's related to theophylline. Theobromine, which you find where? Chocolate, and what else? Most of you guys are consuming it this morning. Caffeine, yeah, caffeine's another big one. So too much caffeine can lead to seizures, right? PCP or phencyclidine, another name is angel dust. You don't see that too much anymore nowadays since we have a lot of amphetamines and whatnot. And then withdrawal is really important here as well. We talk about benzodiazepines and barbiturates. Alcohol withdrawal would also fall in this category as well, right? So again, if you have something that is chronically depressing the system, and I take that away, the brain has some adaptation that occurs where it's used to having that around. If you remove that, all of a sudden you have way too much glutamate activity and thereby a seizure. Lidocaine and lead, and lindane. Anyone know what you use lindane for? Actually for lice. So you may see some lindane-based lice products. And then lithium, which we'll talk about when we get to talking about bipolar later on. So again, don't memorize this whole list, but I just want to give you an idea of just when you're working up a patient with a seizure and you're not really, you kind of take care of the obvious ones like oxygen and dextrose and things like that. This is kind of the list you're going to be going through to try to figure out, okay, well, what other things could they have had a seizure from? And this is where your history and your medication list can be very useful. So anyway, so our treatment goals when we're managing these patients, we would like them to have no seizures. That would be great. Is that always going to happen? No, in some cases you're going to have patients, especially those, we see a lot of them over at Nemours where they have some sort of anoxic brain injury that has occurred that has led them to have kind of irreparable damage done to the brain where they're just going to have seizures. Like, we try to manage them as best we can, but there's never going to be a seizure-free period for those patients. And usually you're going to find that some of those patients are at a mental state where it's not like they would have been leading a typical normal life anyway, but it's still problematic. Like, you still don't want a patient to have a seizure because when you have a seizure, what can occur? You have brain damage due to what? Ischemia, due to the fact you're not breathing normally, right? And that's one of those big things. That's where you'll see when you talk about status epilepticus. Intubation is one of the important things we'll have to worry about for those patients. But anywho, we'd like no side effects. There's a lot of side effects associated with these drugs. So we're going to try to minimize those where we can, as we'll talk about later. And then obviously addressing kind of patient concerns and look at other comorbidids. There's going to be a lot of drug interactions that occur here as well. Not only just metabolism, but also some other pharmacodynamic sort of interactions, as we'll see a little bit later on. We'd like to improve their quality of life whenever possible. But again, not everyone's going to be able to achieve these goals. Some patients have very difficult to treat seizures. Some patients, one drug, and they're good to go. Some patients I've seen on 4 or 5, 6 different medications to try to manage them, and they still have breakthrough seizures, right? So again, it's one of those things where just not everyone's going to be able to achieve these. So things to consider when you're managing a patient with a seizure disorder, especially from the medication standpoint, is looking at their kinetics. And we see the age can have a big effect on this. One of the big ones we'll talk about is called phenytoin. It's kind of one of our old school, kind of gold standard sort of seizure medications. And you would see that based on the age of the patient, that their dose changes pretty widely. And why do you think that is the case? So you think size, but if you look at the dosing, we're doing it as milligrams per kilogram. So we've already taken size into account based on that. Development of the liver, yeah, absolutely. So again, you'll find that when they're, say, like a neonate, and they're very, very young, they may not really have very well developed liver enzymes, as we've seen when we talked about pediatrics, probably in the several semesters ago. But as they start to develop and they start to generate these enzymes, sometimes they will actually have a higher proportion of enzymes than an adult patient might, even based on a kilogram per kilogram basis. So you can see here that at 6 months to 3 years, they need 8 to 10 milligrams per kilogram, but that dose actually gradually backs down to where they get to kind of more normal adult levels. So again, if you were to use a typical adult dose for those patients, or say say like a 2-year-old, that might actually be underdosing them, and then you'd find that their levels would be too low, and they would have breakthrough seizures, right? So those are things you have to consider. And again, we've already taken this into account when you look up in Lexicomp or Micromedics or wherever, that they've already figured this out, and that's where you see those different dosing ranges. And it's important to go back and reconsider those as your patient gets older.
So I don't understand why the dosing goes down as they age in terms of the liver. Wouldn't the liver isn't it like better at metabolizing?
So you find that you'll have kind of a, if you were to look at the kind of the liver enzymes as they occur, as they start to mature, you'd find they kind of start really low as they're neonate, and they kind of peak up, and then as they get older, they start to kind of normalize out to adult levels. So they actually get expressed in a higher proportion for some of them, especially for things like phenytoin, than you would see for an adult patient. Yep, that's why I require a higher dose there.
Thank you.
So different medical conditions can affect this. So again, think about, do they have diabetes? Do they have hypertension? Do they have, arrhythmias? Different other disease states that can interact with some of these medications. And then you also want to look at their ability to comply with the medical regimen, right? So depending on, do these patients have caregivers that can help them with this? One of the big things you'll see as far as side effects go for these meds is CNS depression. And when you have CNS depression, you always remember to take your medications. Not necessarily. So compliance can be a big issue here. And again, when you have a patient who comes in with a seizure, the question is, well, were they actually taking their medications, and how compliant were they being with that? Sometimes levels can be useful for that, sometimes not, as we'll see a little bit later on. And then insurance coverage, there's a lot of new seizure medications that are coming out nowadays. I'm not going to cover all of them here just because I want to get the kind of bread and butter sort of anti-epileptics here. But just be aware that the newer ones are brand name only. They're going to be much more expensive. It may be difficult for patients to get coverage for those. Even though it may be the right med for them, they may not be able to cover it, unfortunately. Okay, so when you're kind of assessing these patients, the first question is, did a seizure actually occur? And we never heard of pseudo seizures? What are pseudo seizures? Fake seizures. Patients are fakers. Would you ever believe that a patient would lie to you? Yes. Absolutely, they will. They will lie, cheat, and steal, especially in the ER setting. Not that I'm jaded or cynical by any means. But yeah, so some people will come in with frivolous complaints, and sometimes what we'll do, especially if they are a seizure patient, we'll do the hand test, where basically they're post-ictal, so to speak, and they're laid out in a bed. You basically just raise their hand above their head, and if you let it drop, and if they move their hand out of the way, then you know they're probably faking, right? Because if they're truly post-ictal, their hand would just hit their head, and that would be it, right? But this person is actually probably conscious, and so you they're kind of fibbing. That's one little way you could do it. But so once you kind of establish that yes, a seizure did occur, the question is, what type of seizure was it? So that has big implications for what type of treatment you're going to be doing for it. So because a typical tonic-clonic seizure looks very different than, say, like an absence seizure versus, say, like a febrile seizure, and the management is going to differ based on that. So like, who gets a febrile seizure? Typically babies, right? And so does anyone know if you treat those normally, like a normal seizure disorder? Typically, no. You deal with a fever, and then they're done, right? And then they're not going to be predicted to have another seizure based on that. So again, the question is, what type of seizure did they have, and kind of establishing that, and then whether or not pharmacotherapy is going to be indicated. So the question is, do you always start treatment for the first seizure? Some people may hold off. Some people may say, well, once you have 2 unprovoked seizures, then yes, we will go ahead and give you chronic management on that. It really depends on the patient and a lot of other factors that go on to this. So again, usually once that first kind of seizure episode is done, you kind of do a full workup, and then you can decide whether or not you want to go ahead and treat that. And again, different neurologists will have different answers for when the optimal time to initiate treatment is going to be. And then the question is, what drug is most appropriate? We'll see that a lot of these drugs are going to be kind of broad spectrum, in that it'll treat many different types of seizures. Some of them are going to be more specific, and so we'll talk about some examples there a little bit later on. And then what are the monitoring parameters? Because some of these you'll have to monitor levels for. Some of them you need to monitor things like liver function, look at their CBC, different things like that, to make sure that they're going to be not having too much toxicity from these drugs, even though they may be good at treating the seizures. So our treatment options, we can have things like antiepileptic drugs, which is going to be the main thing we're going to talk about here today. Keep in mind that none of these are disease modifying. None of these actually fix the underlying issue for why your patient's having a seizure. These are only going to be able to either prevent them from occurring or able to treat and terminate an ongoing seizure, right? So none of these fix the underlying problem. That's the important thing to remember there. A lot of patients can get by with just monotherapy. So a lot of them, about 65%, about 2/3, just one drug, they should be good to go. Some patients are going to be more difficult to control for a variety of reasons. So some of them may require dual therapy. And even then, once you get more meds than that on board, some 20% of patients may never achieve full control. You can certainly limit the number of seizures that they have, but you may not be able to get rid of all of them, unfortunately. There's other things you can do. I'm not going to get into in too much depth here, like vagal nerve stimulators. You can have surgery if there's a particular point in the brain where they know that seizures are originating. Sometimes they will actually go and take that out. But again, it's kind of outside my realm. But we also have ketogenic diets. Anyone know what these are? What is that? High fat diet, low in sugar, right? So it's kind of like an Atkins diet. So very low carb, very high fat, very high protein. The goal here is, anyone know what the point of getting a patient in ketosis is? Lower their pH, yeah. So probably mentioned briefly before, but yeah, so ketogenic diet is very important for some of these patients. What you'll find in general that as you make the body more acidic, it is the neurons become more hyperpolarized, and it'll be more difficult to have an action potential, right? So you're just a very mild acidosis, it's not like you're getting down to like 6-9 or anything like that, but very mild acidosis to try to help those neurons become a little bit more stable, a little less likely to fire off. And so we'll do this for patients who have, we do this, I don't know the proportion of adult patients that have this done, but we see this with some regularity for our more difficult to treat seizure patients who are children over at Nemours. And so one of the things you'll see, and it's very important from the pharmacy standpoint, is that with kids, what dosage forms are we usually giving them orally? We give them big tablets? No, you do a lot of liquids, and a lot of those liquids are going to contain sugar, right? And so that's one of the things you have to look at, because if we knock them out of ketosis, that could lead them to have more seizures, and that's not good, right? It's a medical error we don't want to have occur there. So we'll do things like make sure that in their allergy list, you ever see someone has a dextrose allergy, chances are they're on a ketogenic diet, because that gives us a heads up. They will say, hey, by the way, this patient, is a ketogenic diet patient. You need to make sure you're not going to give them any meds that contain sugar, right? So, but again, that's in order to maintain that mild acidosis helps to hopefully hyperpolarize those neurons and try to keep them from having a seizure. So, but we run into that with some regularity, like I mentioned, and again, it's going to be for more refractory patients. So, again, when you're looking at the optimal seizure therapy, you want to kind of figure out the type and the frequency that's occurring. Usually seizure journals can be very useful, especially if caregivers can kind of help out looking at this. Look at patient goals. What are the goals for the patient? Like I mentioned, not everyone can be fully well controlled. They need to figure out kind of what's better for that patient, what's going to be their primary goals. Next thing, look at drug interactions. I'm going to just say right now, whenever you're giving these antiepileptic drugs to patients, always run an interaction checker. Again, you're not going to remember every single interaction I tell you about here, so look it up. You can lead to some very big issues with some of these, either by having these antiepileptic drug levels get way too high, or it could muck around with other drugs and either make those levels too low or too high. So we want to be careful with that. We'll talk about adverse effects, talk about mechanism. It's important when you're using different drugs, right? So if you need multiple drugs for one patient, you want to make sure you use complementary mechanisms. You don't want to use all the same mechanism, because again, you're not going to get a whole lot extra bang for your buck from that standpoint. Talk about monitoring, and then compliance is going to be big. So if we can try to get meds that are given less frequently, that can be very useful. And then cost obviously is the other big thing there. So monotherapy should be done first, typically. So again, start low and go slow typically, because again, it's one of those things where I can start a patient on a really big dose of an antiepileptic, give them all kinds of toxicity, and they have no seizures. That's fine, but the question is, well, would they've had seizures anyway in the first place? So it's kind of hard to tell, like, how effective is your drug only going to be, and it makes it more difficult for you to titrate down on that dose. So you want to start with kind of more low to moderate dose, see how they respond. If they're still having breakthrough seizures, you can always give more drug. You can always gently ramp up that dose to try to find a happy medium, but typically you don't want to go too hardcore on them right at the very front. And then, again, you can add on additional meds once you hit that kind of maximal dose or maximal tolerated side effects, and you can add on another agent. And then once they have multiple failed therapies, that's when you move on to things like the vagal nerve stimulators and surgery, etc. So, as I mentioned, start low and go slow, and generally watch their response. A lot of times patients don't stop therapy because they're having seizures. They'll stop because of side effects. And so again, that's another important thing to monitor there. And then you may need therapeutic drug monitoring. So that's where we're going to be looking at the levels and making sure we're adjusting the dose based on those levels if they come back too low or too high. And we'll talk more about that a little bit later on. Again, whenever you're switching drugs or you're adding on a different drug, make sure to try to use a complementary mechanism, something different than what you tried before, because that's going to hopefully allow you to find one that a patient is going to respond to a little bit better. Okay, so here's a good kind of flow chart to kind of give you an idea of how you should go about kind of managing these patients. And so it's pretty straightforward and it kind of makes sense logically. You kind of go through, okay, well, did they have a seizure? Yes, I want to go ahead and treat them. The question is, did I start a medication for them? They use ASD here. They call it anti-seizure drug. AED, ASD, doesn't really matter which one you use. But again, you start them up on a medication, and then you kind of figure out, okay, well, are they having intolerable side effects? And if yes, that may lead you down a pathway where you're going to switch the drug over to something else. If they're not having intolerable side effects, and you kind of base it on whether or not they're still having breakthrough seizures, you adjust your dose based on that. If you're still hitting maximal doses and they're still having seizures, that's when you may need to switch to a different drug. So again, just kind of go through that, and it kind of makes sense from a common sense sort of standpoint. Okay, so the main targets we're going to be shooting for, getting into the actual mechanism, we're going to find there's going to be some that work by blocking sodium channels. We're going to find some calcium channel blockers. We're going to see that these are going to be a little bit different than the calcium channels we saw with our other calcium channel blockers, right? You guys remember what type of calcium channels we were blocking with like verapamil and like amlodipine? Actually, L-type, yeah, they're L-type calcium channels, so Gold Star, if you guys remembered. We're going to talk about a few different calcium channel types that'll be useful here. Usually T-type we're going to talk about here. We'll talk about things that help GABA to work better. We'll talk about things that block glutamate, so it kind of makes sense. So again, if we can help GABA to work better, it's putting the brakes on the system. If I can do things that block glutamate, I'll take the gas off of the system essentially. And then some kind of miscellaneous ones, carbonic anhydrase inhibitors. You guys remember where we talked about those before? In the eyes, used for glaucoma, absolutely. So we use them in glaucoma. Anywhere else? Remember in the kidneys where we used them? There's carbonic anhydrase inhibitors that worked in that proximal convoluted tubule. They block the reabsorption of bicarbonate, so you pee out a lot of bicarb. What do you think that does to the body's pH? Should lower it, right? So should lower it because you're getting rid of bicarb in the urine. So again, you're already seeing how we can monkey with the pH in the body. Again, getting a very similar sort of effect as you would see with like a ketogenic diet, right? We'll talk about some hormones. We'll find that in some cases, especially in female patients, that estrogen and progesterone can have an effect on seizures. And there's actually some seizures that occur typically in conjunction with menses, which is kind of interesting. And then there's going to be some drugs that just have unknown mechanisms. There's some that have multiple mechanisms. A lot of times you'll find these newer ones where like, we don't really know how it works. We just know that it works, so we're going to go and use it, right? Okay. So anyway, so looking at sodium channels, this is going to be very similar to what we talked about with looking at those fast response cells in the heart, right? So you remember looking at these charts here where normally you have this resting membrane potential that is being maintained by the sodium potassium ATPase pump. When you have a stimulus that comes along, you're going to have opening of the sodium channels that will cause the potential here to increase quite drastically as sodium flows in. Eventually those sodium channels will close, and that's going to allow for things like the potassium channels to open up. Potassium flows out of the cell, right, because then it's going along its concentration gradient, and that will drop down this potential energy here. And then as that goes down, eventually those potassium channels will close. Sodium potassium pump is going to kick back in, and then you're eventually going to get this repolarization period. Now, what's important about this hyperpolarization right here? Yeah, it's part of that refractory period. So more difficult for the cell to fire off right there. So you can see that if I had an altered level here, if say this was higher, you can see it'd be much easier for that neuron all of a sudden to have another action potential come along and stimulate it. So again, we're going to find that by targeting these different channels, we can affect this pretty dramatically. So sodium channels are going to be one of the mainstays. The first several drugs we had to treat seizures worked by blocking basically these sodium channels, right? And so we're going to find that even though they rest in kind of these three states, you don't really need to worry about that so much for our purposes. Just know whether something is a sodium channel blocker or not. It's kind of enough for our uses here. But you can see that if you were to block these channels, and so some of them will work on different sites of the channel itself. So things like carbamazepine, phenytoin will work at a different site than things like lamotrigine or valproate. So we'll talk about these more in detail as we go along. I just want to kind of illustrate the different targets for our medications and why it would make sense to use, a combination of say phenytoin plus something like levetiracetam or Keppra versus using something like lamotrigine and phenytoin at the same time. Using both of these drugs at the same time wouldn't make sense because they're both going basically for the same target. You won't necessarily get a whole lot of additional bang for your buck, so to speak. So next up we have calcium channels. Remember, they exist in several different types. Mainly we're going to focus on the T-type calcium channels. Again, just know whether something blocks calcium channels is going to be enough for our purposes here. But again, usually by blocking calcium influx into the cell, that again will block, very similar to how sodium works, prevent it from getting get that potential getting as high. It will kind of blunt that effect to some degree. You're going to find this is going to be more important for treatment of absence seizures, and this is where a drug called ethosuximide is going to come up, which we'll talk about later. You guys know what an absence seizure looks like? Yeah, most of you guys are having one during my lectures anyway, so if you just think about that, it's usually, that's my good seizure joke that I have. Anyway, yes, but so again, you'll find that like for things like absence seizures, like they need specific types of medications because they're going to be affecting these different channels, these different targets that work better for those types of seizures. If you might imagine, calcium channel, and again, you'll see valproate kind of come up a lot because that's kind of a myriad of different activities. But again, blocking these calcium channels can prevent that influx. It will prevent the actual potential from getting quite so high. Okay, next up we have GABA targets. So there's two primary types of GABA receptors, GABA A and there's GABA B. GABA A is the primary one we're going to focus on for our purposes. We'll talk more about GABA B when we get into like orthopedics, when we talk about muscle relaxants. So we talk about things like baclofen or Flexeril. We'll talk about those as being muscle relaxants that work primarily through GABA B. Here though, GABA A is going to be our primary concern. So basically when I have GABA come along and bind to that channel, it will open up and allow which ion to flow through?
Chloride.
Chloride flows in, the negatively charged ion that will lead that potential to be more hyperpolarized. It'll make it more difficult for that cell to fire. So again, imagine something, somebody, you guys are right now, very awake, hopefully, lots of caffeine in your coursing through your bloodstream, versus someone who, say, drank a couple of bottles of alcohol. They become very much CNS depressed because they have very pronounced GABA activity, right? They're very kind of mellow. They might be sleeping. That's what GABA is doing essentially, right? So alcohol helps GABA to work better. And so again, it makes it very resistant to help those neurons from reaching an action potential. So we're going to see that when you're wanting to acutely stop a seizure, these are the channels we're going to go with. These are the things that are going to be very useful. Sodium channels would be good too, but when we're talking about kind of acute seizure management, we're going to come back to drugs that help enhance GABA a little bit later on. And so also important to note that the GABA A channels are going to have a benzodiazepine receptor site, and that's where the benzos are going to be working. So we'll talk about those a little bit later as well. Okay. So there's other ways we can affect GABA though. So it's not only that we can affect the actual channel itself, but we can actually affect how GABA is being handled in the neuron. So we can do things like block the GABA transporter. So just like with norepinephrine, just with like dopamine, we have transporters that will allow for recycling of those neurotransmitters, right? So the neuron will send it out into the vesicle. It will then get reuptaken into that original presynaptic neuron, and that allows it for recycling, right? So we can be more efficient with our neurotransmitters. If I block that GABA transporter, more of it will be stuck in the synapse, and thus it's going to have more activity on those channels, right? That kind of makes sense. There's other things we can do too with certain enzymes, so things like glutamic acid decarboxylase. This actually will take, another name for glutamic acid, glutamate, right? So you see glutamate turning directly into GABA. If I were to enhance the activity of this decarboxylase, then I can convert more glutamate into GABA. Kind of two birds with one stone, getting rid of more glutamate, got more GABA now to help hyperpolarize those cells. So that's one way we can do things. And again, just some examples of drugs that can actually affect this. And then the other thing is if we can block the metabolism of GABA. So there's another enzyme called GABA transaminase that actually will cleave GABA and then allow some of those metabolites to be recycled. But if I block GABA transaminase, then all of a sudden I have more GABA available to interact with those channels there. So again, lots of different ways we can do this, and I'll talk about these allosteric sites here a little bit later on. But that's when our benzos and our barbiturates are going to be working at. Okay. So again, imagine here's our presynaptic neuron here. Here's our GABA channels. There's things like benzodiazepine receptor sites. There's places where things like barbiturates are going to bind. And here's where actually GABA binds itself. Once that opens, chloride flows through. Here's that GABA transporter that you can inhibit. Will allow more GABA to stay out into the vesicle space. You have things like the GABA transaminase, which actually will metabolize GABA. And there's that glutamic acid decarboxylase you can also inhibit as well, which is not shown here that I can see. It kind of makes sense. So again, it would make sense. You could have a drug that works specifically on this site here to make GABA work better, like a benzodiazepine, plus another drug like valproate that would actually help to inhibit things like the breakdown of GABA. So again, you can kind of think about multiple mechanisms within one neurotransmitter and how those can both be kind of synergistic. Okay. Next up is glutamate receptors. Primarily for our purposes, just know whether something blocks glutamate or not. I want to talk about a few of the different receptor types, and I'm only going to use this for kind of illustrative purposes here. So just know there's several different types, but glutamate, again, is going to be primarily excitatory. If I can block glutamate, I can help to prevent a seizure from occurring. Normally, when you have glutamate bind, you're going to have channels open up that will allow for inward flow of positive ions. So you can have things like sodium, calcium, depending on the type of channel, and sometimes they'll actually block outflow of potassium. It just really depends on the type of channel it's hitting, on the type of neuron that's going to be hitting there. And so there's 5 different primary sites. There's this AMPA site, kinase site, this NMDA site, glycine, and this metabotropic. Again, you don't need to get so granular right here, but just know that there's different types of glutamate receptors that you can block. Different drugs are having a little bit different activities. And again, when you think about like NMDA receptor blockers, we'll talk more about this when we get to like Alzheimer's and things like that later on. But one of my favorite drugs, Special K, actually blocks NMDA receptors, and that actually helps to lead to a dissociative sort of anesthetic sort of experience. I don't like to use it recreationally, just for professional purposes, I assure you. But if you need to set a bone, like that's a great drug to give. By blocking that glutamate at that NMDA receptor, they get very kind of dissociative, nice chilled out anesthetic experience. You can set their bone. Wake up, 20 minutes, they're good to go, right? So again, different varieties here. They all have different activities. So for instance, you have things like levetiracetam, which is quickly becoming one of our go-to seizure drugs, called Keppra, blocks the NMDA receptor, versus things like topiramate can block the AMPA and kinase receptor. So just know there's a little bit different activity. If you were to go into neurology or do a rotation there, you might need to get more specific on these, but just know whether something blocks glutamate or not. I'm not going to get super into depth on this. Just know that typically will allow for inward flow of positive ions, and that's why it allows them to be so excitatory, typically. Some of them are going to be more like linked up to secondary messengers, especially that metabotropic site. Those are going to see more like G proteins and things associated with them. Okay. And then just kind of for the miscellaneous category, you can see things like progesterone and estrogen can definitely play a role here. So typically what you'll find is that progesterone has an anti-seizure sort of effect, versus estrogen having more of a kind of a pro-convulsant sort of effect. And so again, depending on the patient and where they're at kind of in their cycle, and we'll talk about that more when we get to the OB-GYN section, I think, which is coming up next. We'll talk more about that, and you'll see how the levels of the hormones can actually affect how those levels will change throughout the month. And you can see how some patients may be more prone to seizures at certain times when their estrogen levels are high while progesterone is low, and things like that. So we'll talk more about that. And then right now, we don't have any drugs that specifically affect this, but just know that is a concern for some patients. And then we talked about carbonic anhydrase inhibitors, how that helps to make the body a little bit more acidic, causing a little bit of a mild acidosis, and that helps to hyperpolarize those cells. Okay, so there's over 20 available drugs we have for treating epilepsy and treating seizures. Not all of them are going to be covered here, just because I want to get kind of the bread and butter ones you're going to run into most commonly. But just know there's some other ones that are out there, a lot of newer ones that are out there that we don't have a ton of experience with, and we're still learning a lot of things about them, including side effects. Because again, when you put a drug out into the market, how many people have you studied it in? Like 1 million people? Probably not. Maybe several thousand, right? Maybe tens of thousands, but when you're looking for a 1 in a million or 1 in 10 million sort of side effect, you don't find those until they're out into the general public, right? And so it's one of those things where as we get more experience with them, we'll become more familiar. But things like phenobarbital, things like phenytoin, they've been around for decades. We know very well what their problems are, what their nuances are to using them, and we feel very comfortable with them. So those are the kind of big ones we're going to cover today. Let's see. Now you find that a lot of the newer ones, which is kind of interesting, that a lot of the newer ones that get marketed, they really only test them as an add-on therapy because again, it's kind of difficult to run studies where I'm going to give you, say the gold standard seizure medication, I give someone else a new one, which don't really know how effective it is. So most of the time they get marketed and they get approved for add-on therapy, right? So if you're going to use two or more drugs. But you'll find that many providers will use these, even though they're not labeled as such, as monotherapy, and that's okay, right? So again, as you get more comfortable with the drug, you kind of learn more about it, you find that most of these are probably going to be effective, and they generally have equal effectiveness as a lot of the older medications as well. It just depends on the patient, how they respond to it. But there's no really good head-to-head trials to figure out which one is the best seizure med, like who is going to be best to receive phenytoin versus valproic acid versus carbamazepine. No one's done those studies. No one's probably ever going to do those studies. You just need to kind of have a trial and error sort of period where you can say, okay, you're going to try this drug, doesn't work, let's go on to this next drug. And it can take people a while to kind of find what's best for them. So again, it can be a long, arduous sort of road. And it really is going to depend on the patient, the provider, and several other factors like comorbid conditions, costs, things like that. Some neurologists, they really love only going with, Keppra for things. Some other people say, that's no good. I want to go ahead and use this other drug instead. And so again, a lot of it can be provider specific. Hopefully it's not based on who just bought them lunch. Hopefully it's based on a little bit more scientific evidence than that. But again, it can be very provider dependent. I don't know if you guys are. But. So someone pointed out that I was remiss in not including cannabis in my talk here today. I do cover cannabis a little bit in the pain management section in orthopedics, so it'll come up probably in the next section of the class. But can you use cannabis for seizure management? You've heard that, right? So you've heard this. Was there any caveats to that? What? Yes, studies. Studies are useful, right, for helping us to determine if things are clinically useful. So with cannabis, what's the primary psychoactive compound? It's THC, right? It's tetrahydrocannabinol, delta-9 tetrahydrocannabinol. But that's not really the one we use for seizures. It's not really the good one for seizures. What's the other thing we can use? We find in cannabis that we can use? CBD, which stands for cannabidiol, right? So there's cannabidiol, and that's the primary thing they think might be helpful in preventing seizures. Is there a lot of psychoactive effects from CBD? No, and so that's kind of a good thing. So again, because a lot of these seizure medications typically are causing your patients to be more sedate, right? And so if you think about a little kid who needs to go to school, you probably don't want them to be quite as sedate, right? Because again, they need to, just like if you guys imagine if you had to do PA school challenge mode and do a couple shots of alcohol before you come into class for the day, your grades might suffer a little bit, right? Because again, you're not going to be able to retain a lot of information. You're going to be a little bit more sleepy. Not good, right? Same thing happens with a lot of these seizure meds. So there was a strain of marijuana they produced for a period of time called Charlotte's Web that actually had very low THC levels but very high CBD levels. And so that was the one that was available for use in Florida for a period of time, back before Morgan got his way, right? Where we were able to use that. And so I actually saw 1 or 2 patients who were actually on Charlotte's Web for seizure disorder. So the question is, well, when do you use it? So should I use it for every patient who has a seizure? No, typically we want to go with things that have a little bit more history. We have a little bit more history with. We have studies to support use of. However, if they fail almost everything else and I got nothing else, then yeah, absolutely, let's give it a try, right? And so that's typically what you're going to find with a lot of the cannabis literature is that it's not a slam dunk for any one particular condition. It doesn't necessarily beat out your gold standards. However, there's some efficacy with it, right? So it's one of those things where typically you want to use kind of the standards of therapy first, go by the guidelines, and if that's not working, then you can try it as a backup, see how it does for your patients, right? Because again, a lot of people are like, well, it's natural, man. It's got to be good, right? God wouldn't have put it in the ground and not expect us to smoke it, right? Okay, yes, but there's also cyanide in apple seeds, and you don't see us chowing down on those either, right? So again, with all things, you have to consider what the evidence is and whatnot. So that's that. Any questions about that? That probably won't be on this test specifically for this. We'll cover it later on as far as from pain management standpoint. We'll talk more about the other kind of ancillary uses because it does have a wide range of utilization. And then there's starting to be some more epidemiologic studies coming out saying hey, all these patients with chronic pain issues, once they go on medical cannabis, they're dropping their opioid usage, and that's huge. That can be a really big deal, especially with the opioid crisis going on right now, killing a lot of people. Right, so accidental overdose is becoming a big deal as far as mortality goes. I think it's outstripped car accidents and things like that. So anywho, off of that tangent, back onto the topic at hand. Much like you might do should you consume THC, right? Anyway, so Phenytoin is one of our gold standard go-to drugs. It's starting to kind of take a little bit of a backseat nowadays due to some of our newer medications that lack some of the side effects you're going to see with this. But Phenytoin is still one you're going to see used with some regularity. And so Dilantin's the brand name we see used most often for it. And so this is working exclusively as a sodium channel blocker. So block sodium channels, prevent influx of sodium, prevent the actual potential, hopefully, from occurring. If it does occur, it may be blunted to some degree, right? So that's primarily how it's working for seizures. This is a highly protein-bound medication, so it's around 90% bound to albumin. And if you remember, drugs that are bound to serum proteins, are they active? No, they need to be free of the proteins in order to be physiologically active to interact with those sodium channels in the CNS. So if they're bound to albumin, it's not going to be active drug. And that's going to be important when we talk about that a little bit later on as far as the kinetics go. So I don't know if I've mentioned this before, but have I talked about Michaelis-Menten kinetics before? Do you guys remember we talked about elimination of drugs? There's zero order and first order kinetics. So first order kinetics was what? Most drugs follow first order kinetics, right? This is where you're metabolizing the same percentage of drug per unit of time. So if I have a higher level, I'm still going to metabolize, say, 30% of the drug per hour. It doesn't matter where that level's at. I'm always going to do 30%. Versus zero order kinetics is what?
Depending on the dose, how much is metabolized?
Well, it's going to be the same amount of drug per unit of time. So just like I said, with alcohol, it's a zero order drug where it's only going to be 20 milligrams per deciliter per hour, right? So it doesn't matter how high your level is, it's only going to metabolize that certain amount per unit of time. So it never changes. So phenytoin is sometimes difficult to work with because it has this Michaelis-Menten kinetics where it flips. You know, I said most drugs are first order kinetics, but if you get a high enough level, you outstrip those enzymes, the ability for them to metabolize, and they switch over to zero order kinetics. And so what do you think that does to the half-life of the drug? Get shorter or longer? It gets a lot longer because again, all those enzymes they're busy, right? They're all busy trying to metabolize phenytoin. Once they get saturated, it switches over to that zero order kinetics. Half-life extends out super long. So that's a problem. So imagine we had one patient who came in. They came in for breakthrough seizure. They're a known seizure patient. They were on phenytoin at home. Came in, and so when you have a seizure patient having a seizure, you want to give them a bolus of their medication in order to try to eliminate that seizure, right? So we said, okay, we're going to give you a bolus of phenytoin. Again, what's the point of giving a bolus of a drug? It helps them get them to the steady state faster, right? It's like a loading dose we're giving them. So we gave this lady a loading dose, phenytoin. It stopped her seizure. She was feeling fine. But then for whatever reason, when their shift change that occurs, and again, most dangerous things happen on a shift change, as you might imagine, the outgoing people did not document that dose had been given. So the oncoming resident said, okay, we need to go ahead and give you a bolus of phenytoin, ordered it. Nurse went ahead, who's new, went ahead and gave it. All of a sudden, the patient, she didn't know any difference. All of a sudden, the patient had 2 boluses. Right, so now she's presumably double her steady state, and so she switched over from that zero order, first order kinetics over to zero order, and her levels were super high. She was very dizzy. She was ataxic. She was having nystagmus, feeling pretty miserable, and her levels were going to stay high for a long time because that half-life extended out pretty significantly. That if we didn't make any intervention, she would have been in the hospital for a week or two in order to work off that drug. Right, so that's one of the difficulties where small changes in dose can really affect phenytoin pretty significantly. And again, another reason why we're starting to use this a little bit less frequently than we did once before. Anyway, we actually ended up giving that lady charcoal, activated charcoal in the gut, and actually that pulls the drug out of the system a little bit faster. So we were able to get her out of the hospital like in 3 days or something like that. So it's actually kind of a nice thing we could do for her. But anyway, so the other thing, so this is metabolized by a CYP enzyme, so primarily 2C9, 2C19. Remember that from warfarin. That was another big drug that got metabolized by these 2C9 and 19 enzymes. But the big thing to note here is that this can induce CYP3A4 and also the CYP2C family. So if you have another drug, so imagine you have a patient with AFib who's on warfarin, and you give them phenytoin for their new seizure, guess what? Now their warfarin levels are going to be higher or lower? They're lower because we're inducing those enzymes, right? So we're inducing them. There's more enzymes available to metabolize the warfarin. Levels go lower. All of a sudden the INR goes down, right? Because again, the vitamin K is not being antagonized, and all of a sudden they can throw a clot, right? Or they develop a clot and they can have a stroke or something. So again, think about these relationships where if I induce an enzyme, how that's going to affect the levels of a different drug, and how that can affect whatever the primary monitoring parameter is going to be for that. So you have to kind of think in the stepwise approach where if I induce those enzymes, drops warfarin levels down, they'll drop the INR down. Not good for your patient. So big interactions there. I'm not going to talk about the absorption too much, but in general, you can utilize phenytoin for generalized partial seizures, not typically for absence. We'll talk about one drug in particular. It's good for absence seizures, but phenytoin, very wide category, or is able to use for lots of different types of seizures. It's a very good drug from that standpoint. So the main side effects, and you're going to see this with the majority of these drugs, is because they're inhibiting these neurons from having action potentials, lethargy, sedation is going to be the primary side effect for many of them. So you can see that blurred vision. Generally, you start low and titrate up gently, and that will help to alleviate some of those effects as the body kind of gets used to having that drug on board. Can be very useful. Other side effects which are problematic, hirsutism. Especially for young women that all of a sudden are starting to grow a mustache, right? Not so great for them. So that's another thing they might not utilize this drug for. You can also have gingival hyperplasia, so all of a sudden the gums start to kind of grow out of control, which is pretty terrifying. I honestly don't know that. May have something to do with metabolism of say estrogen, perhaps maybe by inducing those enzymes you will drop estrogen levels, and that maybe lead you to be more pro-androgenic. I just pulled that right out of my rear end. But it sounded pretty good, right? Sounded smart. It's 90% of my job is just try to say it with confidence. Anyway, I'm just kidding. So anyway, so good oral hygiene. So again, make sure they're really brushing their teeth really well. Make sure they're taking care of their gums. Can help with a lot of that. So that's a very common one they'll run into. And then actually what's interesting is you can actually have vitamin D deficiency that develops from use of phenytoin. This is more of a chronic problem that can lead to osteomalacia, osteoporosis. So they would recommend giving supplemental vitamin D and calcium if you're going to be on phenytoin for the long term. And again, very good first line drug. This is another one that is available IV. I'll kind of point out whether they're available IV or not. Not for testing purposes, but just so you can get an idea of like when you're managing these patients, how you might give these drugs, right? So again, for kind of chronic management of preventing a seizure, what type of dosage forms might I use? Probably like oral dosage forms, right? So I might use like tablets or capsules or liquids, things like that. But if I was trying to, terminate an acute seizure, what route do I want to go? Yeah, so like IM, IV, the parenteral routes are going to be more effective for treating an acute seizure, right? So again, kind of keep that in mind. And again, another big thing you're going to find with a lot of these anti-epileptic drugs is that skin rash leading up to things like Stevens-Johnson syndrome, toxic epidermal necrolysis is also a big risk as well. So again, very rare that it occurs, but when it occurs, it can be life-threatening. So you need to make sure patients are aware of that. If you start to see new changes in rashes, if you start to see any kind of skin blistering, things like that, get them to come in. So you need to get off the drug. And get evaluated for that and maybe switch over to something else, right? Actually, I had a kid several months ago who came in who was actually on, I think they're on Lamictal, which we'll talk about a little bit later on, and then a different drug. And actually, both of them could cause Stevens-Johnson. So they came in and actually had to get taken off both of those drugs to try to figure out, okay, well, which one was it? Because it's really hard to determine when they're on both at the same time. But anyway, so that's another big thing to be worried about. So again, all these side effects, you can start to see if we have newer drugs that are a little bit less toxic, this one's going to start to take kind of a backseat. And that's kind of what we're seeing here, is that a lot of some of these other drugs we're looking at today are going to be kind of getting more use as a first-line drug. Here's an example of going from that first order where, again, you're doing kind of constant percentage of drug per unit at a time. So again, as the levels are higher, you're metabolizing more drug over that hour period. As the levels get lower and lower, and then they'll start to metabolize less and less drug, versus zero order, where you're just doing the same amount of drug per unit at a time. It really is irrespective of how high that level is. And so again, half-lives tend to extend out pretty dramatically once you switch over to zero order, and that can be bad for your patients because they can get very, very CNS depressed. They can get very, fall risk are huge for these patients as well, and their levels get too high. So again, always keep that in mind. Okay, so just to give you an idea of kind of how we dose some of these drugs, I'm not going to have you memorize the dose, but just to give you an idea, this is one we do a loading dose, because again, it's a fairly long half-life, and we want to get up to steady state quickly, so that way we're not worried about the patient having a breakthrough seizure while we're still getting those levels up. So we'd give them something like a 15 to 20 mg per kilo bolus, get them up to that steady state, and then you can switch them over to PO dosing, essentially, once they're kind of under control there. And notice that the dosing is going to range pretty widely based on the type of the age of the patient you're dealing with, so always look that up prior to prescribing. And then this is another one we do therapeutic drug monitoring on, because again, we want to make sure that levels are high enough to prevent a seizure, but not so high we're going to have toxicity or possibly induce other seizures. So that's one thing to watch for. And so notice here we have a total phenytoin and a free phenytoin level. What do you think the difference is here? Yeah, so total actually measures all the phenytoin that's in the blood, irrespective of whether it's bound to albumin or not, right? So when you get a total level, that gives you an idea of how much is actually there in the blood. Useful, but not as useful as knowing what the actual amount that's available to interact with the receptors are. So that's where our free levels can be very useful. It's more expensive, and for a long time, a lot of places did not do this reliably. This is a send-out lab that took a few days to come back. And so basically, phenytoin is 90% protein bound. So that means typically if a therapeutic level is 10 to 20 for a total level, that 1 to 2, or basically 10% of that, would be a normal free levels. And kind of that's where we got these values from. And so this is important because you can have patients who have altered albumin levels, as I'll show you in just a second here, who can affect that, right? So if I have low albumin levels, what do you think that does to that percentage of drug that's free? It would increase, right? Because there's less proteins actually there to bind up the drug. And so I'll show you a few examples here in a second, but just be aware of that. Those free levels can be very useful. If you're having a patient who has a normal total level, but they are still acting like they're really kind of ataxic, and they're having really bad nystagmus, and they feel dizzy, that's something where a free level can be very useful, because you may check that and be like, oh wow, actually the free level is way higher than what I would have expected to be. That's why you're so toxic right now, right? So things you can do is hypoalbuminemia. So if you have a patient who has like poor nutritional status, typically albumin is one of those things that kind of goes by the wayside. Renal failure can do this, and then we'll see this with critically ill patients. They tend to deplete albumin over a period of time. So this is where replacing that can be useful occasionally. Otherwise, you can try to correct the underlying issue. And then occasionally, if you have multiple drugs that are all bound to the same protein, they can have interactions there where you can have some competition for those binding sites. Okay. So phenytoin itself does not like to go into solution, which means that if you were to give this IV and it were to extravasate, and you guys remember what that term extravasate means? Yeah, it goes outside of the vein essentially, right? So if you blow a vein, or if you were to give this intramuscularly, this does some really bad damage. I think the pH of phenytoin to get it into solution is around 10 to 11. It also has a bunch of alcohol in there, has things like propylene glycol, a lot of like really just nasty substances to try to get it into solution. Not very good. So because of that, you can end up having what we call this purple glove syndrome, where if it extravasates, you can see some very bad tissue necrosis. This is why, like, for instance, when we use this drug for pediatric patients, we want to make sure we're using the deepest vein possible, make sure we use the largest vein that we can find, which as for pediatric patients is already problematic because their veins are a lot smaller, a lot more difficult to get in the first place compared to an adult patient. But sometimes we still have to use phenytoin because we have a good safe alternative called phosphénytoin. Phosphénytoin is the brand name is Cerebix. I didn't include that on there, but it's actually a much more water-soluble prodrug. You just put a phosphate on the phenytoin, all of a sudden it's phosphénytoin, and then it's much more water-soluble. It's much easier on the veins, and so we'll use that instead. A lot less phlebitis, a lot less pain associated with it, but occasionally you run into shortages. So we actually had an issue where phosphénytoin was on shortage because it wasn't the drug, we couldn't get enough of the drug. The issue is with the actual glass vials. There's glass particulate that was coming off of the vial on the inside and actually getting into the drug. And so obviously we do not want to inject glass into our patient typically, and so they had to recall a bunch of that. And so now, now we're stuck with phenytoin. We have to use this as for these patients who are coming in with an acute seizure. So it's kind of problematic, but you have to be able to work with both essentially. So anyway, just note that phosphénytoin is the more water-soluble version, much better for IV use, and that's what we would prefer to use in most cases. Okay, that's it for phenytoin. Up next, we have carbamazepine or Tegretol. Some of these drugs you're going to see have multiple off-label uses, and so some of these we'll talk about. I'll just kind of mention briefly here. You're going to see them come back up when we talk about our behavioral meds. Later on, especially with bipolar disorder. So a lot of these can be what we call mood stabilizers, or basically they will help with patients who have bipolar disorder, this will help kind of bring them down from their manic states and kind of help prevent those from occurring in the first place. And so carbamazepine is a really good one that I see many patients use for this purpose. But originally it was a anti-seizure med, and so it's a sodium channel blocker. And kind of the unique thing with its metabolism is it has an auto-induction of its own metabolism. Anyone know what that means? Kind of like ramps up its own metabolism. So it's actually, if I were to give the same dose to a patient over the course of say a few weeks, you'd actually see the half-life will get shorter and shorter and shorter because those enzymes that are responsible for metabolizing get upregulated. And so this is where we're going to see that actually has an interesting titration associated with, I'll show you in the next slide here, where over the course of several weeks you actually kind of increase the dose gradually, not because the patient wasn't effective at a particular dose, but because we know that that level is going to be dropping due to the fact those enzymes are upregulated there. But anyway, as far as drug interactions go, this one's also pretty bad as far as inducing CYP3A4, 2C9, 2C19. So again, a lot of drug interactions. You really need to watch out for this, especially when you consider using this in your behavioral patients. They end up getting a lot of meds associated with that as well. So if they're on an antidepressant for their depression, and then they're on these mood stabilizer, and then they're on something, maybe an antipsychotic, and they're on all these different meds, interactions can be very, very problematic here. So watch out for that. Again, dizziness, diplopia, it's very common adverse effects due to that kind of CNS depression effects there. This one also want to watch for LFTs, cause some hepatotoxicity, so watch for that. And then what's an interesting side effect, you're going to see this is going to be, this and oxcarbazepine are big with this one, cause hyponatremia. And so it does this by causing, I guess remember we talked about SIADH, ever mentioned that? What is that? Yeah, it's a syndrome from inappropriate antidiuretic hormone. So basically your brain's sending out too much ADH, you're going to be holding on to too much water, it dilutes out your sodium, and thus you get hyponatremia, which again, I already mentioned, if you have too low sodium, what can that cause? It can cause seizures. So again, so the question is, okay, well, a patient has a seizure disorder, they're on carbamazepine, they come in, they had a seizure, is it because their levels were too low, is it because the levels are too high, or is it their sodium, right? All these things you need to consider checking. And then you can also get some transient bone marrow suppression, so you can see things like thrombocytopenia, leukopenia associated with this as well. Again, CBCs, LFTs, sodium, these are all good things to monitor with carbamazepine. Here's an idea of how the titration would go. So based on the week, you would titrate up. You know, you can see like you have to basically, quadruple your dose practically in order to get to a steady state where they will be at a therapeutic range. And again, it's due to the auto-induction. So you have to consider that. You don't want to just start them on one dose and then leave them there because the levels will come back almost negligible, right? This is another one we'll do therapeutic drug monitoring on. Again, I'm not going to have you memorize the levels for the test, but just be aware of them. They might show up on the test, and I might ask you, hey, patient level comes back at this. Here's the therapeutic range. What do you want to do with them, right? So that might be a test question that comes up. So just keep that in mind. Okay. The cousin to carbamazepine is going to be oxcarbazepine. You cannot actually get good levels for oxcarbazepine, even though they're structurally similar. You can't do the levels interchangeably, unfortunately, but this is trileptal. This is another one you may see being used as a mood stabilizer for bipolar disorder. And really the big thing to note here is that there's less drug interactions because it doesn't really induce those liver enzymes the same way carbamazepine does, but it has a higher propensity to cause hyponatremia due to that SIDH. So less drug interactions, but more hyponatremia. So again, it's kind of a double-edged sword with that one. Next, we have valproic acid. This is another good mood stabilizer drug. I see this one being used probably more commonly than carbamazepine for that indication. And in fact, again, with a lot of these patients with bipolar disorder, you're starting to see these used much more for this indication rather than seizures in a lot of cases, right? But anyway, so valproic acid, you may also may see it called sodium valproate. Might be another term, but if you see valproic acid, valproate, just know this is basically the same drug. There's lots of different brand names too, so like Depakote, Depakine. A lot of them have to do with the formulation, whether it's an immediate release or extended release. Just be aware that extended release formulations are really good for these patients because the less often they have to take it, more likely they are to be compliant with it. So that's why you have all these different formulations available. So valproic acid is kind of a hodgepodge of different mechanisms. It can block some sodium channels, will block some calcium channels. It can also help to increase activity of GABA, which can be very useful as well. So again, multiple mechanisms, probably why it's so effective at treating seizures in the first place. As far as adverse effects go, we'll see some sedation, some ataxia, tremor. GI disturbance is probably a little bit more common than those. But just be aware that this can also lead to things like weight gain, pancreatitis. I don't know if you remember going through your I've seen different acronyms for things that can cause pancreatitis. I think tablets is one of them, but you'll see valproic acid will show up on some of those because it's kind of more known to cause pancreatitis than some other drugs. See some hepatotoxicity, thrombocytopenia, so I'll be aware of that. You can see all these with valproic acid. Again, pretty well tolerated, but when they do occur, it can lead to some issues. One of the interesting things with valproic acid, at least to my mind, is it can actually cause a carnitine deficiency. And carnitine is actually used in your mitochondria and it helps to process ammonia. Anyone knows what happens when you have ammonia buildup in the blood? It's a pretty potent neurotoxin, so actually it can lead to some pretty significant CNS depression, altered mental status. And so we actually had a young man who came into the, he's probably 15, 16, comes into the ER because school, he said he was at school, he passed out in his chair, and they said, oh, he must be taking something. He must be high on goofballs, right? So I said, okay, we'll bring him in. So he came to the ER, and you look at his med list. You ever heard of the term goofballs? People get high on goofballs, and thus they have to come to the ER. But yeah, it's an old school term, I guess. Anyway, despite my own anachronisms, this patient came in. He, because again, when you see a teenage child or teenage adolescent who comes in, altered mental status, one of the things you have to think of is abuse of drugs. And so we were trying to work him up for several things, and we saw that he was actually on valproic acid for his mood disorder. He kind of has this oppositional defiant disorder. So they're trying valproic acid, try to kind of stabilize his mood out a little bit. And so we checked a level. You'll see that you can actually get levels for valproic acid. I think I have it on the next slide here. And so it was normal. So okay, well, maybe something else. Maybe something else is going on where he must be on alcohol, have alcohol on board or benzos, and really everything else will come back negative. And I said, well, why don't we check an ammonia level? Sure enough, the ammonia came back sky high, and it's due to this carnitine deficiency caused by the drug. So again, always have to think outside of the box, think about other alternative diagnoses for some of these things. And so once we actually gave the patient carnitine, we're actually able to get those levels back down. He's back down to normal. So it's just a simple thing. We had to take a carnitine supplement, and that was able to remain on the valproic acid. Anyway, so from a drug interaction standpoint, oh yes, ma'am.
Sorry, but does the oxcarbazepine or whatever, is that a sodium channel blocker?
That is also going to be sodium channel blocker. Yeah, think of that with carbamazepine is working very similar. They're cousins essentially.
Okay.
Yep. So this one can inhibit 2C9, so again, not inducing those enzymes, but actually inhibiting 2C9 now, and also this UGT pathway. So this can be important because it affect drugs like lamotrigine, which we'll see just a little bit, and things like lorazepam, which again is another big seizure medication we'll use pretty frequently. Again, be aware that therapeutic range can be malleable, right? So for seizure patients, you may shoot for, say, 50 to 100, but for bipolar disorder patient, you may go above that, right? You may, just depends on the type of patient, how they're responding to things. And keep in mind, just because a patient has a level that's outside of that normal reference range, do you always need to treat that? No, you always want to make sure you're treating the patient, not the number, right? So again, if they have a level that's low, low versus the reference range, and they're having no seizures, no side effects, don't touch it. If the level's a little high, no seizures, no side effects, don't touch it, right? So again, just be aware those therapeutic ranges are just guidelines. Think about a normal distribution. If you go 2 standard deviations out, what percentage of the population are you missing? I'm covering 2 standard deviations of a normal distribution, 2.5% on either side, right? So again, 5% of those people are going to fall outside of that normal range, assuming it's normally distributed. Just to bring back EpiBio just for a second there, right? I guess probably purged all of that. It's okay. This is also pretty teratogenic. So pregnancy, I'm not going to get super in depth on this right now, but pregnancy in patients with epilepsy can be very, very difficult because again, you worry about drug exposure, and some of these drugs can be pretty, really problematic from a teratogenic standpoint. Valproic acid, especially because it can cause neural tube defects. You can see things, big issues with that. It's not easily remedied just by giving folic acid like you would see for normal patients. But so just be aware, you know, especially in the organogenesis period, during the first trimester, a lot of those patients might know they're actually pregnant, right? So we'll talk about oral contraceptives a little bit later, but just be aware this can be a particularly problematic kind of issue for some of these drugs. Okay. Next up are benzodiazepines. This is kind of a broad category. We're going to talk about these later on when we talk about them in the behavioral section. How do we use benzodiazepines from a behavioral standpoint? Anyone know? Anxiety, that's one of the big ones. So panic attacks, anxiety, anything we're getting very anxious, benzodiazepines are good drugs for that. We use them very similarly for seizures, just at a higher doses typically, in order to try to hyperpolarize those cells by allowing the chloride to flow into those neurons, by basically allowing GABA to work better, right? So there's an actual benzodiazepine site that will bind to, allows GABA to bind more readily, allows the chloride to flow in more readily. So we will use benzodiazepines primarily for kind of termination of an acute seizure, right? These are not great for kind of chronic prevention of seizures. There'll be some exceptions to that, but typically these are going to be really good for just kind of acute seizure management, okay? We'll talk about why we don't use them chronically as much due to some side effects later on. But basically you have things like diazepam. When we use it for seizures, typically you're using it in the rectal gel formulation, because imagine you have patients having a tonic-clonic seizure. You know, is it easy to get IV access on them? No, right? They're kind of writhing around the floor. It might not be super easy, especially in the before EMS even gets there. You need to treat their seizure somehow. So a lot of patients, just like they have EpiPens for anaphylaxis, they'll have Diastat ready to go for seizures. And this is where patient education can be so important, because you need to educate caregivers. Because is the seizing patient going to give themselves Diastat? No, they're having a seizure, right? And they're not going to be able to do that. So caregivers need to know how to do that. So that's one of the big things we do at the ER at Nemours, is I will actually educate parents on how to administer it. Because when your kid's having a seizure, I've not experienced it personally, but I imagine it's a pretty harrowing experience, and you need to have some education on that beforehand to know how to respond to that. So again, and it's, you know, they have to take their pants off, and you have to make sure you use like the proper lubricant on there, because otherwise it can cause rectal trauma, all those things. So this is why education is so important there. So that's a big one we'll use. Lorazepam or Ativan is probably the most common one we'll use IV in order to treat acute seizures. It's probably our go-to drug here. You can also use it orally occasionally for more kind of like, you know, more anxiety purposes, but IV is really the go-to route for this. And then also midazolam or Versed is another big one we'll see being used. This is actually a good one where we're actually starting to use this intranasally more often. So you can actually have a nasal atomizer where you'll drop the drug into a syringe, attach this atomizer, and it produces this very fine mist that we just kind of shoot it up into the nose. And so we're actually, some of our neurologists are prescribing this instead of giving them the Diastat. So that way, instead of having to like get their pants off and do all this stuff, you can just kind of give them a little shot at the nose, and that is very effective for treating the seizures, very similar to the diazepam as far as efficacy goes. So that's kind of a good thing. So we're starting to see a lot of midazolam being used. Just some other ones we'll see sometimes clonazepam or Klonopin. You see this a lot for kind of chronic management for some of these seizure patients, especially in kids. And then a new one called clobazam or Onfi is a kind of a newer one we're starting to see with some regularity. Okay, so again, their side effects are going to be pretty much the same regardless. We'll talk a little bit more about their kinetics and whatnot in certain patient populations later on in the behavioral section. But for our purposes here, we're generally using these for you know, treatment of acute seizures. You guys remember what this means? C4? It's a controlled substance, right? So again, you'll find that a lot of seizure meds are not controlled substances. I will point out where they are. And so these, again, are controlled substances, which means they are going to have more regulation around them as far as, patients getting them filled and things like that. So again, these are a little bit more restrictive and they become a little bit more problematic to prescribe than just simple, non-controlled sort of substance there. But we'll see that some of them are going to be renally metabolized, some hepatic. We'll talk more about that later in the behavioral section, and we'll talk about fat and water solubility a little bit later on. But just be aware these are go-to drugs, especially if you're using the per rectum route, the intranasal route, IV, IM. Benzodiazepines are really good for treating the acute seizure that's happening right now. Not as good for more kind of chronic maintenance, like you would see with something like a phenytoin or carbamazepine. Again, sedation is the most common adverse drug reaction. Again, imagine someone who's drunk a bunch of alcohol. It's very similar to the effects you would see because, again, they're both working to help GABA to work a little bit better. And these, because of the fact that you can have tolerance develop over time, especially for those who are on these benzos chronically, they need to withdraw these drugs very carefully because if you withdraw all of a sudden, you can see withdrawal seizures, and that's very problematic. You don't want to cause that to occur. So again, if they're on it chronically, you need to withdraw slowly in order to make sure you prevent those seizures from happening. That make sense? The brain's used to having all that GABA activity, and all of a sudden you take away that, and all of a sudden you have less GABA activity. Glutamate's going to kind of take over, and you'll see that seizure occur there. Okay. So those are the benzos, and next you have the barbiturates, and so phenobarbital is one of the big ones. One time I had a patient come up and ask me to refill his peanut butter balls. It took me 10 minutes to figure out what the heck he was talking about. Phenobarbital, very old school drug. It's probably one of the first anti-epileptic drugs we actually had. Very, very old school. But this works similar to the benzodiazepines, but just at a different site. And so again, they're helping those GABA channels to open up, allowing more chloride to flow in. These tend to be more sedating than you see with the benzodiazepines. And so because of that, we don't use them quite as often, especially for patients who need to have kind of normal daily activities. So if they need to go to school, if they need to go to a job, like barbiturate's not going to be great for that. But we do use them as a drug of choice for neonatal seizures, and so you'll see this very frequently. If you have a neonate who comes in who's having a seizure, phenobarbital is probably one of the go-to drugs we'll use for that. So it's a very common one there. Again, not used quite as often just due to the adverse drug reactions. The other big thing you can see if you're giving especially big IV boluses of a barbiturate, you can see hypotension. You don't really see it quite as much with the benzos, but barbiturates you can see some drop in blood pressure. It can be problematic for some patients. And again, this is also a C4, so it's going to be a controlled substance. So again, sedation, CNS depression are the biggest things you can see. Sometimes actually with kids, they have these what we call a paradoxical reaction. Did I mention this with Benadryl before? Yeah, same thing can happen here with barbiturates. Also, actually, benzos can do this as well. So if you give a kid a dose of lorazepam or give them a dose of phenobarbital, they might get extra excited. Some that has to do with some of the kind of the circuitry that's going on there as far as inhibitory neurons and whatnot. If you give them more of the drug, they will sedate eventually, right? So it's one of the things where you can just give a little bit more, and typically they'll kind of get through that. This one is metabolized by CYP2C19, so watch out for interactions there, but will it also induce 2C9-3A4? Another reason why we don't like to use this quite as much due to these drug interactions. Okay. Let's see. Sometimes we'll use this for refractory status epilepticus. So I'll go through kind of a flow chart a little bit later on how you kind of decide which med you're going to use for status. But this is one drug you may use there. And then also a therapeutic range is available. This one's much more kind of a wide therapeutic range you see for some other drugs because, again, there's some patients who, due to the tolerance effects that occurs here, similar to the benzos, they can be on very, very high levels and be somewhat relatively normal as far as mental function goes, and that may be what they need. So I've seen some patients give them the 60s, 70s, 80s and be totally fine. It just really depends on the patient. That's kind of a general range we'll shoot for. We've never heard of pentobarbital? This is actually a drug we'll use occasionally. This is actually a C2, but this is one it has the same mechanism as phenobarbital, but it's very, very potent, very strong drug. If you need to put someone down for general anesthesia, this is a drug you can potentially use for that. So sometimes we'll have patients who are refractory to all other drugs, and when we're trying to treat status epilepticus, we'll actually use this and put them, basically just snow the entire system down. Obviously, when you get a patient this sedate, you're going to also have to do what to their airway? Yeah, to intubate. You have to make sure you're protecting their airway, make sure you can breathe for them, because they're not going to be breathing when they get a big enough dose of the stuff on board to treat some of these really difficult to treat seizures. So a little bit of trivia. Don't look at your slides. Give away the answers. What are the 3 drugs that we use for lethal injection, most typically? Potassium chloride, that's good. That is, when do you give that one? First, second, or third? Third, yeah. That's actually what's going to be the thing that kills the patient. What does potassium chloride in a big bolus do? stops the heart, right? So again, if you imagine, and that makes sense if you think about the sodium potassium pump and the way the potassium is going to be given. If you put so much potassium on the outside of the heart, it's going to basically prevent that repolarization from ever occurring. It's going to lead to basically the heart just stopping, right? So, and then we also do that a lot for like cardiothoracic surgery. If you never need to like do what we call cardioplegia, where actually you're stopping the heart, putting the patient on bypass, potassium is a big component of that. So potassium is one. What else? So we'll give a sedative, yeah. So it acts as an anti-anxiety medication, but basically we're giving a sedative. Basically, you get such a big dose, and actually, pentobarb is one of the ones you can use, or sodium thiopental is another one. Works the same as far as barbiturates go. So you have that. This will basically put the patient out, will knock them out essentially. You have one of these two, and then you actually use pancuronium. Anyone know what this is? It's actually a paralytic, so it actually will paralyze the patient, and then you'll give them the potassium. So the idea is you can sedate them enough, because again, you never want to paralyze somebody who is conscious, right? So you want to get them very well knocked out, then you'll paralyze them. Which again, if I paralyze somebody, what's that going to do to them? We're not intubating them either. They're going to stop breathing, right? So that would have killed them anyway. But just for good measure, we're going to give them potassium on top of that and really make sure they're dead. So this is a typical 3 drugs you would give for lethal injection. So just if you were ever curious what medications are there, just to kind of add a little levity to our discussion today, right? Anywho. It is a derivative thereof. Yeah, so curare is a if you think like poison dart frogs and like pufferfish and things like that. Yeah, you think about things like curare, and that's where that comes from. Anyway, so another drug occasionally used called felbamate or felbutol. This one's not really used too often due to a lot of hepatotoxicity that comes along with it. This one's actually works a little different because it actually will inhibit NMDA receptors and enhance GABA activity. So it's got a novel mechanism, maybe useful for some patients, but due to the side effects, namely this potentially fatal aplastic anemia and hepatotoxicity, we don't use it too often. Just want to mention it here as an option for really refractory patients. Next up, we have ethosuximide. This is actually going to be strictly a calcium channel blocker for those T-type calcium channels. This is the drug of choice for absent seizures. So if you ever have a patient with petit mal or absent seizures, this is the drug to go with. So again, it could be a good kind of board style question, or you might see it on rotations or something like that. Or they might ask you. This is a good pimping question. Not really useful for much else. Well tolerated, but again, it's just not really effective except for these one particular cases. So not used too often. Next up, we have gabapentin and then pregabalin. These are very structurally similar to one another. Anyone know what we use these for other than seizures? Yeah, so what type of pain? Neuropathic pain. So you think about diabetic neuropathies, think about fibromyalgia, things like that, any kind of neuropathic pain. This is where these two are really getting a lot more use nowadays than strictly for seizures. I don't know that I've ever seen anyone actually use these drugs for seizures, but we mention it here just because they kind of fit into the category. Even though they're structurally related to GABA, they don't actually help GABA to work any better, like that. They probably have a little bit more activity, calcium channels. Some of them may actually help to enhance GABA synthesis. But again, even though they're structurally related, they don't actually work the same as GABA. They don't actually interact with that receptor at all. These are also nice because these are actually 100% renally eliminated. So if you had a patient with really significant hepatic issues, this may be a good alternative, right? Because most of the stuff we've already seen, phenytoin, carbamazepine, valproic acid, those are primarily hepatically metabolized drugs. So if you need to go something that was more renal, these are good options for that, which is nice. And so a lot of times they're either used as an adjunctive agent added onto another antiepileptic, or more often, as I mentioned, it's even used for neuropathic pain. So we'll talk more about pain management in the later section, but this is where I see a lot of these being used. And then and they're pretty well tolerated. The main thing is just a little bit of CNS depression. Not probably as significant as you might see with like a benzodiazepine or barbiturate, but certainly you'll see some CNS depression associated with that. And then just to note, gabapentin itself is not a controlled substance, but Lyrica or pregabalin is. It's actually a C5. So it's actually the lowest level of controlled substance you can get before a non-controlled substance. And so it's probably related back to some studies where somebody mentioned euphoria they were experiencing, and that probably got it listed as a possibly abusable drug. I've never seen anyone actually abuse Lyrica before, or any reason why you couldn't abuse gabapentin in the same way. Doesn't really make sense, but that's the way the FDA works. Okay, next we have lamotrigine or Lamictal. This one is another one you may see being used for bipolar disorder as a mood stabilizer, and then nowadays also being used occasionally as monotherapy as first line for some seizures. Again, blocking sodium channels, also working to inhibit some glutamate release, which is good, and then modulate some of those calcium channels. So kind of multiple mechanisms. You can see how it might be useful for some patients who are not really responding to just like say strictly a sodium channel blocker or something like that. Big thing to note here is because you still will see it used in polytherapy, or if you're using multiple drugs, you have to watch out for the interactions here. So for instance, you can see that its metabolism is severely inhibited by valproic acid. If I mix these two together, lamotrigine levels are going to skyrocket, right? And so that can lead to some toxicities here, as we'll see. But it can be induced by other drugs like carbamazepine or phenytoin. So I'll show you an example of how we can work around that based on the type of drugs you're combining it with. But the biggest thing to watch out for is going to be rash. It's one of the primary adverse drug reactions and really kind of typical of lamotrigine. Be careful with that. Make sure you're slowly titrating. And due to that risk of Stevens-Johnson, at least one of the black box warnings for this one, if you see it, they need to stop therapy immediately. They need to make sure they come in and get checked out because, again, Stevens-Johnson's toxic epidermal necrolysis can be fatal if not caught and managed early, right? Other than that, typical, a little bit of minor CNS depression, but pretty well tolerated.
So you said SJS is a black box warning?
I believe it's a black box warning on that one. Yeah, you can double check me, but it's one of those things that like you think lamotrigine, you think rash. Like, it's kind of one of those common associations you make there. Even though you still see with things like phenytoin and carbamazepine, like this is kind of more the poster child for that sort of thing. So just to give you an example, if you were to look at like a drug reference, you would find that they would have dosing based on, are you mixing it with an enzyme inducing med or are you mixing it with an enzyme inhibiting med? And it's important to make sure you are dosing this appropriately because otherwise, if the levels drop or get too high, you end up seeing a lot of that rash start to pop up here. Levels get too low, you end up seeing breakthrough seizures. So again, be very careful with that. Make sure you look it up beforehand. Okay, don't memorize that. Just know that this can be affected pretty dramatically by both enzyme inhibitors or inducers. All right, Keppra, this is starting to be kind of like liquid gold for a lot of neurologists. This stuff is like, they give it to everyone basically. So it's levetiracetam, or Keppra. Most people just call it Keppra. So this one actually has a very novel kind of mechanisms binding to the synaptic vesicle protein SV2A. Basically, this is one of the proteins that helps those vesicles when they're in that kind of presynaptic neuron to help translocate it to the surface of the membrane to allow it to kind of expel the neurotransmitters, basically. It's kind of a novel mechanism, but basically it helps to prevent that binding from occurring. It helps prevent that neurotransmitter release, and that's what's thought to lead to its seizure mechanism, anti-seizure mechanism, I should say. Like I said, very few side effects for the most part. You can give huge doses to patients, and they tolerate it like champs. So for a lot of patients where they might use phenytoin originally for like management of an acute seizure, I'm starting to see they're going to use Keppra more often than not, at least in the pediatric standpoint. That's what I'm seeing very frequently. And so the other big thing is the lion's share of it is eliminated through the kidney. So again, if you have hepatic issues you're worrying about, this is another good drug to use. And as far as drug interactions go, one of the kind of unique things you can see with this one is they found in studies, you actually found increased aggression, especially in children, being found there. So again, it's one of those things where let the parents know that, hey, if you notice, little Jimmy's acting a little weird, he's acting a little bit more aggressive, maybe pushing kids down at the playground, that could be it, right? He could just be a normal kid, or it could be that this increased aggression is kind of showing itself. Up next, we have topiramate or Topamax. Anyone know what you use topiramate for? Any off-label indications? Yeah, migraine prophylaxis. So this is when we talk about headache disorders a little bit later on, probably tomorrow. We'll talk about Topamax being used for that. Actually, another indication you may see it being used for occasionally, it will be for weight loss. Some people use this off-label for helping patients to lose weight as kind of because a lot of weight loss drugs, for those who don't know, tend to be stimulant sort of drugs. So you have things like amphetamines, you have things like ephedrine, things like that have been used historically. A lot of issues with using drugs like that I won't get into here, but this is another one that they found in studies actually caused some weight loss, so some people started using that as an off-label. I'd say that's whether it's good or bad, but that is a side effect to be aware of. Again, this one's going to have a myriad of different activities, so it's blocking sodium channels, enhances GABA activity, and it also actually has some anti-glutamate activity here as well by working against these amphetamine receptors. The other thing it has is a little bit of this carbonic anhydrase inhibitor activity, so it will cause a little bit of an acidosis. So again, we saw that's already beneficial for our seizure patients. Not the primary mechanism, that's an additional one. But the other thing you have to watch out for is this can cause kidney stones. So especially patients who are predisposed to that, they're more likely to see a kidney stone due to Topamax being added onto their regimen. So watch out for that. The other thing, impaired concentration is kind of listed as a common side effect for Topamax. So again, if a patient is in school or if they're at a job that really requires a lot of concentration, like their flight controller, probably not a good drug for them to be on just due to that impaired concentration they can have with that. Okay, here's another new one. This one is becoming, I'm seeing it used more frequently for some of our pediatric seizure patients, called lacosamide or Vimpat. This one is actually also a C5 as well. It also is nice because it has an IV form available. A lot of the ones we've been talking about, besides like phenytoin, besides Keppra, besides valproic acid, and the benzos, really don't have a lot of good IV options for seizures. This one does provide us an option for that, which is nice. And it works by kind of a novel mechanism. So not only blocking sodium channels, but also working with this collapsin response mediator protein. I don't actually know how that works for seizures. They don't really know either. It just says, hey, we know it interacts with this, but how it works for seizures, no one knows. There's another new one, so we don't have a ton of evidence or a ton of experience with it like we do with some other drugs, but some of the things they can see include some cardiac conduction anomalies, like shortening of the PR or increasing the PR interval, I should say, and then some typical nausea, vomiting, etc. So those are the main meds you're going to see being used for treatment of seizures. So that's kind of the main ones I want to talk about for today. Any questions on those? Okay, so you have a patient who comes into the ER for an acute seizure. One of the things you always want to ask them, especially if EMS brings them in, is like, what have they already received? Okay, so when you already want to figure out what they've already been given. Oftentimes, EMS will give usually a dose of a benzo en route for those patients, right? So either if they have an IM dose of Versed, or if they can establish an IV, they might give some lorazepam. Depends on the unit you're dealing with. Typically, the patient will come in having already received a dose of a benzo. Maybe not, just depends on the patient. But the primary thing they do when they roll into the ER is you want to do what first? ABCs, yeah. So you want to maintain their airway, breathing, circulation. Those are the biggest things to handle first. Because again, things you worry about with patients who are seizing, especially for a long period of time, is they're probably not breathing, right? So the other thing you have to consider is like, did they, had they vomit? Did they aspirate? Any of that stuff? Like, those are all concerns you have to consider with these patients. And so it's not uncommon we have to intubate these patients for protection of their airway, because not only is the seizure causing this issue here, but also a lot of the meds we're giving can cause CNS depression, respiratory depression. So you need to make sure you're protecting the airway from that standpoint as well. So airway circulation is a big thing. Early on, benzos are going to be your go-to drug for treatment of an acute seizure. It's happening right now, right? So lorazepam is a really good one to use. As I mentioned, outside of the hospital, diazepam can be used in the per the rectal route. Midazolam used intranasally. Those are all good options as well when you don't have IV access, right? Because again, it can be very difficult, patients having a tonic-clonic seizure, to get IV access started, okay? Now, typically, they don't respond to that. You may give several doses of a benzodiazepine. You want to go to kind of the next line. You always want to have another backup drug in your mind, because if you don't break that seizure, you need something to go to after that, right? So next up, traditionally what you'd use is something like phenytoin or phosphenytoin primarily. So I still see a lot of, especially like older school, like ER docs, like they still go with phenytoin as their go-to drug here. Although nowadays I'm seeing a lot of neurologists recommending Keppra now. So it just depends on the patient again. Depends on what they're on outside as well. So for instance, if they're on Keppra at home, they might be more predisposed to give them Keppra, give them another bolus, try to get their levels up to treat them there, right? Because the drug's already on board, might as well just give more of that drug, right? That's one thing to consider doing. If that's not working, then again, it kind of becomes more nebulous based on the patient, based on the providers. But things like, phenobarbital might be another option you'd use after that, right? And so, and again, as far as like test questions go, I'm not going to ask you specifically, what do you use after phenytoin? What do you use after this? I might say, like, okay, you give benzos. What's another option that you could give next? I might have like, lorazepam and say, well, that's already benzo. We already tried that. But phenobarb, okay, that's a good option to try there, right? Because again, it really depends on a lot on your patient. But if these are not working, you can try things like valproic acid, possibly. And then if they're still not working, this is where you can get down to general anesthesia and possibly even a pentobarbital coma. So again, just basically just CNS suppress them to the point where they are comatose. They're basically, you could do surgery on them if you wanted to, and then get them up to the ICU. Get rid of them, right? So that's kind of the general way of things. Again, start with benzos, and then you want to go down kind of a stepwise approach through some of these other meds that we mentioned here. That make sense? Hopefully? Okay. We had one patient, you ever heard of non-convulsive status epilepticus? That one's really tough. We actually had a patient, a little old lady who's probably like 9,000 years old, I think. Came in, she was on Theophyline at the nursing home for her COPD. Probably started back in the 60s. And no one had really been watching her levels. No one had been watching her renal function. And so she ended up getting really toxic levels of Theophyline. Once that gets in the CNS, it's really hard to get rid of it. So she came in status epilepticus, and we ended up giving her several rounds of benzodiazepines. That wasn't working. We tried. Problem with toxin-induced seizures is that they don't respond to a lot of these normal kind of drugs you'd use for a typical epilepsy patient. We actually use a drug called propofol. Anyone ever heard of propofol before? We'll talk about that in the surgery section later on, but propofol is a good general anesthetic agent. We tried using that on her. And the other thing to consider is when you intubate a patient, you're also giving a paralytic, right? Because you want to make sure you're kind of loosening up all these muscles, that way you can get the ET tube in. And the problem is you paralyze a patient. Can you tell if they're seizing? No, because all the muscles are paralyzed, right? So you can't actually tell if they're actually having a seizure or not. That's why EEGs are very useful for that. You can actually tell and still see if they're having a seizure on the EEG. Unfortunately for this patient, she ended up having, once the paralytic wore off, she still wasn't having tonic-clonic contractions. But when you actually hook it up to the EEG, she's still having very obvious seizure activity. So we call it non-convulsive status. Unfortunately, that patient ended up passing away due to that, but it was a very sad case. But it's one of those things where, even though the patient is not actually having tonic-clonic, contractions, doesn't mean they're not actually still seizing. So it's one thing to always consider. Okay, any questions on that? Yes?
So as you're going down that list of drugs to use, you can consider what they're using at home and maybe throw that in there somewhere?
Yeah, absolutely. So if there is an IV option available for that, because again, these are always going to be IV once you have an established IV access, right? So again, if they were on something like carbamazepine, there's not really a good IV option for that, so I wouldn't give that necessarily. But if they're on phenytoin at home, then yeah, certainly I can give them phenytoin here as well. The other question you have to consider is well, was the patient compliant? Like, are they coming in seizing because they were not compliant with their medications, right? This is where history can be very useful, especially if family members you can interview to try to get an idea, were they taking their meds like they're supposed to? The nice thing with kids is their parents are usually the ones giving the medications. They have a pretty good idea if they're actually giving the meds or not, right? Versus if it's someone like an adult coming in, they might not have anyone there with them, you have no idea. And so you can try to get levels, but that takes time, right? And when you're dealing with a seizing patient, time is tissue in a lot of cases. So, try to look to see what they're on before. If they're on phenytoin, give them a dose of phenytoin, see how that goes. If they were on Keppra before, we give them Keppra. So it just really depends on the patient. But, yeah. Any other questions on that? Okay. I think, let's see, you got 4 minutes. I'll give you guys a 4-minute break. Okay, so that's it. We'll have... I'm very sorry I did not do the schedule. You have me for 2 blocks tomorrow for Friday afternoon. I will likely use every last minute. I apologize for that. I don't want to be here either that late, but it is what it is. So, otherwise, I will see you guys tomorrow then. Thank you.